Okay, so now we are recording this urinary tract system surgery or genitourinary surgery part 2. Part 2 is we are going to go through some more terminology. As you are seeing, here, these terminologies are mostly associated with kidney and mineral that is being filtered through the kidney. Albumin is a water-soluble plasma protein. So albumin can be present in the urine. That means kidney is not filtering the albumin from the urine efficiently. So there may be some kind of kidney disease. Albuminuria is the terminology associated with presence of albumin in the kidney, in the urine. So protein is circulating in the blood, not filtered. That is a problem there. Now, calculus. Calculus basically means mineral salt that is present in our body now being accumulated in high concentration and blocking the organ duct system and ureter, kidneys, renal pelvis area. It could be in the gallbladder also, but calculus is a big problem. We call it stone in the kidney or stone in the urinary tract. So mineral salt, when it becomes solidified and stone, it has to be removed. Otherwise, the urine cannot circulate from the kidney to the bladder to the urethra outside of the body. A patient cannot eliminate the urine. It's a painful condition, so he needs emergency surgery depending on where these stones are blocking. Dialysis, as you know, is a process of removing all the waste product from the blood of a patient when the patient's kidney is not functioning. When the patient kidney is not doing that job of removing waste product from the blood, then they have to depend on dialysis machine to do this work. Outside of the body, this machine sits and the tubing is implanted into the patient's arm, basically, and the vessels there, and the shunt there. That is where the dialysis needles usually go in, AB shunt. And these are the patients with renal failure. Most of them are having partial kidney failure. Some of them got total renal failure and having in dialysis and waiting for a transplant of kidney. You know, electrolytic solution, they have ion in them, positive ion or negative ion. like water, you can divide it water into hydrogen ion, positive, and oxygen into negative ion. Sodium, you can find sodium in our body as a sodium positive ion, and chlorine you can find in our body as a chlorine negative ion. So positive and negative ion, when it is floating in our body, it can conduct electricity. So that is why we call it electrolytic. When we find patient's blood is lacking some of these electrolytic component, then surgeon usually orders electrolytic solution through IV to replace the lack of electrolytic in the body of a patient. So electrolytic, you will hear that term. And the reason we are talking about electrolytic solution here is we don't want any type of electrolytic solution to use during endoscopic bladder and urethra and ureter related surgery. When they're removing or dissecting tissue inside the bladder, the urologist uses electricity. And if we have electrolytic solutions as irrigation, that is going to conduct electricity and it's going to actually electrocute everywhere that electrolytic solution is reaching in the body. That means instead of electricity go to the targeted area of the tissue to dissect, electricity will zap or electrocute everywhere the electrolytic solution is going, causing a big problem. So electrolytic solutions are not used, and we need to know what are those electrolytic solutions. Saline is electrolytic solution, normal saline. Water is mildly electrolytic solutions. So we need to not use them for irrigation during urology surgery because it can electrocute the bladder area. When surgeon is removing tissue by blunt dissection without cutting it, they sometimes use finger, and using their finger, they go around the tissue and remove it from the capsule without cutting it. Prostate is one of the organ. When the surgeon is removing them at the final stage, when all the blood vessels are clamped and dissected, ligated, at the final stage when there is no more blood vessels to cut, it is just attached to the capsule area, then they use finger to kind of blindly and bluntly dissect it away and remove it totally. That is enucleation. So you need to know the term enucleation, that when the surgeon is doing that, we can call the surgeon is, at this time, surgeon is enucleating the prostate. Fulguration. Using electricity, high power electricity with the bovie, when surgeon can destroy dissolved tissue, that is called fulguration. Usually surgeon is destroying what type of tissue in the bladder? Prostatic tissue. cancerous tissue in the bladder. So when they see cancer or prostate overgrown, they can use this cautery to dissolve those tissue and use suction to get rid of them from the bladder. That is a procedure by itself, fulguration of the bladder. Also, fulguration means when there is a bleeder actively bleeding inside the bladder and surgeon sees it in the endoscope and they control it using the bovie, that is also called fulguration. So they are coagulating that bleeder. Hematuria is a term associated with blood in the urine. Hemat is blood and urea is urine. So if you put together those prefix and suffix, you get hematuria. That means presence of blood in the urine. So next we have condition. Impotence is a condition that you know that is associated with male fail to achieve any type of erection for the purpose of intercourse. That is called erectile dysfunction. They may have nervous system problem, or they may have the spongiosa cavernosa and spongiosa area, blood vessels related problem. The problem can be solved with penile implant or some sphincter reconstruction surgery. Hydrocele. This is when the scrotum is filled with fluid and it gets enlarged. Hydrocele can be repaired by opening up this fluid-filled sac and suctioning out the fluid and closing back up. So hydrocele is a fluid-filled sac enlargement of the scrotum. Very quick operation, couple of minutes. Surgeon will prep and drape and then take a 15-knife blade, cut open the sac and put the suction in. All the fluid will be sucked out and they will just close it back up and put a little bit of ointment dressing, collodion, and that's it. That's all they have to do for hydrocele. Testicular torsion could be an emergency procedure. The twisting of the testis and causing the trauma. If it is left twisted like this, this can necrose the testis and would cause a reproductive problem. That is why surgeon will have to open the testis and untwist it manually to repair the testicular torsion problem. This is also a quick surgery and you will find them done sometime on an emergency basis. Urinary incontinence. Usually this happens to elderly people, elderly patient, where their pelvic floor is not strong enough anymore and their bladder sphincter is not strong enough. So every time the bladder gets a little bit of urine, maybe 10 cc, 30 cc, like that, and the sphincter opens up, and the patient don't have control. They cannot close the sphincter by voluntarily, and that is why they have urinary incontinence problem. The urinary stress incontinence is a similar problem. Here, the opening of the sphincter can be caused by laughing loudly, sneezing, coughing, or lifting certain weight. Same problem of the sphincter, weakness of the sphincter. How do they fix this problem? They suture around the sphincter and tighten it up, close it up, and that is how the urinary continence problem can be resolved. Varicocele. Elderly people get enlargement of the veins of the spermatic cord. So what happens is we have the spermatic cord. Let me show you spermatic cord. In this picture, you can see spermatic cord, or other name is vas deferens, which originates in the testicle at the epididymis site. Epididymis is basically functional element of the testis. That is where the sperm matures and stores. Epididymis then originates the vas deferens, or the spermatic cord. This cord kind of courses its own journey from the scrotum into the front side of the symphysis pubis bone, goes inside the inguinal ligament, underneath the inguinal ligament. You find it underneath the inguinal ligament. Then it goes inside the body. It's already inside the body, underneath the skin, but it goes inside the pelvic cavity through the inguinal ring, inguinal ligament, and it reaches the backside of it transverses to the backside of the urinary bladder, comes on top of it, on the side it comes and empties into the ejaculatory duct, which is the main channel of the urethra. In this course of travel, the spermatic cord gets stuck or compressed sometime underneath this area, this inguinal ligament area, top of the bone, but underneath the inguinal ligament. And this is where the pain, along with this vas deferens spermatic cord, which gets enlarged. And what is going to happen when we have enlargement of this vein structure? It is going to cause pressure on the spermatic cord. And this spermatic cord is very, very sensitive, because it's along with that cord, there is a nerve structure going along, pudendal nerve. When you have pressure on the nerve, then it causes pain. So the patient complains about constant or pain around when they move around, and the patient requires a surgery. This vein has to be repaired, or the varicocele, they open it up. Again, very small, minor procedure. They open it up and free up this vein so that it is not causing any compression, tissue damage. We are discussing how the kidney is producing urine by filtering the blood. And we discuss how the kidney is located in a retroperitoneal space. And where we find retroperitoneal space, which is along the border, lateral border of the psoas muscle. The muscle that runs downward from, actually, muscle is originated in the iliac crest, the pelvic girdle, and goes upward to the rib and the spine where it is attached. Here you can see the left and right kidney located at the retroperitoneal muscle area. Left kidney, which is higher because it has a lot of space underneath that rib area. But the right kidney is lower because that space is occupied by the liver. And the area, if you cut it open coronally, again, the midsection where the renal artery, renal vein enters and exits the kidney, that area is concave and it's called hilum. Hilum basically comes from the word hiatus. Hiatus means opening. So hilum is the opening or concave opening of renal pelvis area where all these blood vessels and ureter also comes in and out. Whole area has a thick, you can see this fatty looking tissue. It acts as a padding and also as an attachment to the muscle. It's called Georda's capsule. It's basically a fascia, a tissue, a connective tissue fascia. On top, you have the adrenal gland that is sitting at the tip. So this is our normal kidney anatomical location. Kidneys are removed for many different reasons. One of the reasons that you see here, enlargement of kidney for polycystic kidney disease. This kidney is kind of looking 4 times larger than normal kidney, and it is removed because it's not functional anymore and it is causing pain and suffering for the person. So this has to be removed. So they do nephrectomy. In this case, they have done total nephrectomy. So they have removed both kidneys out of the patient's body. Now, kidney, if you look at it through the microscope, if you magnify it 10 times, Then what we see is, if you go in the coronal section, in the midsection of this kidney, cut, slice in between anterior, posterior. And if you remove the anterior section of the kidney and you're looking inside the plane, coronal plane, the posterior mid posterior view, you see blood vessels, large blood vessels, renal artery and renal vein going in and out. You see a funnel-like structure right here, this yellowish kind of funnel-like structure of white color or yellowish color. And then you see there are pyramid-looking or trigonal-looking dark brown structure. They are like units of dark brown triangular units, number of them in a very nice half moon circle arrangement. And you see these blood vessels are going in, then surrounding these trigonal looking dark brown structure. You also see the tip of the trigonal structure or pyramidal structure's tip is channeled into this filter-like structure. So now to go and identify each area, each structure, we usually go from outside of the kidney to the interior all the way up to the ureter and the venous structure. Outside, we told you we have this layer of fatty pad layer, Gerotus capsule. You open the Gerotus capsule, then you get the surface of the kidney, which is very nice and shiny and very smooth. This surface has a layer called cortex. This cortex layer is the first layer of the kidney, right around this area surrounding. This is cortex everywhere, the outside layer. Then if you go further down, you go into medulla. Medulla is this section right next to the cortex, these triangular looking area, pyramid looking, this dark brown areas. Now, medulla is surrounded by blood vessels, vein and artery, arterioles and venules, capillary beds. Big artery and vein become smaller artery, arterioles, and then capillary. Tiny capillaries surrounding this medulla. They're going in and out of the medulla, causing tubular structure. We don't have to go into the detail about the convoluted tube, loop of Henle and all those, but you know that they're there. You have learned that in the anatomy and physiology lecture. That is the terminal end of these tiny little blood vessels into the medulla. Now, medulla now coming to the tip, and they call this tip renal papilla. And then if you go further, a little bit down, this papilla is surrounded by calyx. Calyx becomes enlarged group of calyx. Each calyx is coming and collecting the urine from the medulla and channelizing this urine into the major calyx where there is a funnel-like structure. Minor calyx connected to this medulla, collecting the urine. Minor calyx brings the urine, dumps it into the major calyx. Major calyx then becomes renal pelvis, really the opening of the funnel. It takes the urine down to the large section of the ureter where it starts. So area of renal pelvis then becomes ureter. Then ureter courses downwards into the bladder. And you see the blood vessels everywhere through this tubule. Medulla, the functional unit, nephron, what we call. The nephron, the functional unit of kidney, which is located in the medulla, filtering the blood one cell at a time. So unique, so precise. One cell can pass through this medulla renal tubule and kidney, filters, puts back what is good for the body, like sodium, potassium, calcium, magnesium, chlorine, blood vessels related, all the RBCs, red blood cell, white blood cells, all of these electrolytic structure, they put it back into the blood and takes out the nitrogenous waste, urine, and that goes into the renal pelvis to drain into the bladder. So this is our kidney in a nutshell. So when we have disease condition of medulla, disease condition of the renal cortex, pelvis, we have big stone sometimes grows here, grows and slowly occupies. We can see certain unique picture of renal stone some patient may have, which the stone looks like it filled the whole renal pelvis, and it is jagged because of the calculi, and that can cause tremendous pressure and pain, and it blocks the urine to go down. Person will have problem, big problem. So urologists, they do many surgery to remove the stone from this calyx and renal pelvis and ureter. We have a little bit more time before we take a break. So you're gonna go few more anatomical terms. Adrenal glands, it's a gland situated at the top of kidney. This gland is a major contributor of many hormones to continue our growth process. Retroperitoneal organ. Inner section is, as I told you, outer section is cortex, inner section is medulla. Also responsible for epinephrine, norepinephrine, and which are two hormone substance. They are vasoconstrictor, means they constrict the vessels. So when the vessels are bleeding, these vasoconstrictor can constrict and stops the bleeding or transfer of blood. The outer section cortex of this adrenal gland secretes steroid hormones, aldosterone, cortisol. These are the hormones we require for our stress related condition. And we have androgen, the male hormone. So adrenal gland is very, very important functional gland. Sometimes we have adrenal gland tumor, and then surgeon will remove the adrenal gland. Ureter, as it comes out from the renal pelvis, it is about 25 to 30 centimeter long and diameter at the start about 5 millimeter, and then it kind of narrows down when it enters the bladder. There are areas where there are major curvature of this ureter because of the natural contour. First curvature, where we get stone lodged, is called ureteropelvic junction. Ureter and pelvic area junction. That is where you see the major curvature, right here at this level. Then another curvature, as you can see, where it is crossing over the iliac arteries. And the last curvature is at the backside of the urinary bladder, where it is orificing the urinary bladder. So 3 curvature, 1, 2, and 3. All of these are prone to lodge stone or calculi, and the surgeon has to diagnose that where the stone is situated and use instruments or sometimes open surgery to remove the stone, to open up the blockage of the urinary tract again. Urinary bladder structure is a organ located the hypogastric region, located way below, right above the symphysis pubis. Right above the symphysis pubis, if you touch, you can compress the bladder. Stores the urine, and when it is full, it empties the urine by opening the sphincter, by opening the orifice, internal and external, passing the urine down to the urethra. Collects urine from ureter. It has a large gland, prostate gland, situated at the neck, right around this area. Here's the bladder. Here's the bladder's orifice through which urethra starts. And at the base of the bladder, there is this gland called prostate gland. Prostate gland secretes prostatic fluid. It secretes prostatic fluid into this duct system here, through the duct system. we call ejaculatory duct or prostatic duct, empties into this ejaculatory duct. Now, urethra continues, sphincter right here, external sphincter. It compresses and expands, relaxes to let the urine pass. So bladder, prostate, and duct structure, and the urethra. So urethra takes the urine from the bladder to the outside of the body. And semen and urine can also use the same passage, male urethra, which is 20 to 25 centimeter long. Now, female urethra is narrow and short membranous tube, 3 to 5 centimeter. Urethra structure, bladder structure is anterior to the vaginal canal for female, and in the male it is anterior to the rectum. So it's the anterior-most structure, the anterior-most opening for patient, any human being. Now here we can see male urethra here, bladder, prostatic juncture, prostate and prostatic urethra. Then we have this membranous bulbular urethra, continues through penile urethra to the urethral meatus at the glands. There are some glands here, prostate glands and bulbourethral glands or seminal vesicle glands, which is right here. They all have duct system, and it contributes to the semen. We are going to see the prostate gland individually, because this gland hypertrophied and it causes obstruction of the urine transmission. That is when we call benign prostatic hypertrophy, and surgeon needs to go in there and resect the prostate partially or totally. They can do endoscopic resection or open resection of the prostate. Prostate has a function to secrete highly alkaline fluid. Alkaline fluid, which is above pH of 7. 7 is neutral. Anything below 7 is acidic, and anything above 7 is alkaline. And prostate gland secretes this alkaline fluid to keep the sperm alive. Sperm requires alkaline fluid, and that is one of the reasons sperm is produced and stored outside of the body in the scrotum. Inside of the body, temperature is higher. Outside of the body, there are a couple of degree Fahrenheit difference. And the fluid, the condition there is alkaline. Those two conditions are required for sperm to stay alive, stay functional. Otherwise, sperm cell, these are individual cell, they dies. So prostate gland creates that alkaline fluid, lots of it, and emulsify covers this each sperm with the alkaline pH high level fluid. So prostate's alkaline fluid comes out through the prostatic duct into this ejaculatory main duct, where we also find the vas deferens spermatic cord, which empties its sperm, semen. Then it becomes, when it meets prostatic fluid from these two tiny little gland, bulbourethral gland, seminal vesicle. So all three little glands, prostate, seminal vesicle, bulbourethral gland, they adds more fluid to give volume for the sperm that comes from this vas deferens, and give alkaline base so that it can flow through this urethra and can come out through this glands at the meatus, through this meatus. This is the male reproductive organ system. So we have, in the scrotum, we have testis, manufactures the sperm through the spermatozoa, stores and matures at the epididymis, a convoluted structure here, comes out through the this vas deferens or ductus deferens into the ejaculatory duct, into the prostatic urethra. These two glands, which is situated right underneath that urinary bladder called seminal vesicle, they also secrete fluid that also comes into the prostatic urethra right here. Bulbourethral gland, they secrete some fluid that is also comes into this juncture of prostatic urethra. Then everything comes out through this channel. So primary male reproductive organ. If somebody asks, what is primary male reproductive organ? Answer would be testis. If the person has sperm, they can make baby in a test tube or in other medium. But if they don't have sperm here manufactured in this testis, then they cannot reproduce. So primary organ, male organ is testis. Primary reproductive female organ is ovary. Without ovary, ova will not be produced. Sperm and ova cannot make the uh, reproduce, cannot uh, make the embryo and move forward with the reproductive cycles. Okay, so as you can see, we discussed this male reproductive hormone structure and male reproductive primary structure and vas deferens, how it originates in the testicle and runs through the inguinal canal uh, and all the way up to the terminal portion ends at the ejaculatory duct. And we saw seminal vesicle and prostate gland and bulbar urethral gland. Here's another lateral view. So in between the AP and lateral view, anterior, posterior, lateral view, we get a very good idea how this vas deferens is progressing or coming out from the testicle, the scrotum area, and ends at the prostatic urethra. So the reason we need to know this, because there are a few surgeries that is common for vas deferens. One of the surgery we're going to see is the resection, cutting this vas deferens so that the semen, the sperm cannot come to the prostatic urethra. So we will talk about that. So for the time being, we just know the how this male reproductive organs are functioning. Now, Cooper's gland, it's also known as bulbourethral gland. We showed you that. Where it is located, we're going to go back again and see right where the prostate ends, and there is a little, tiny little structure about radius of couple of millimeter, less than couple of millimeter radius. This structure, we have two of them to the left and right, and this is bulbourethral structure. This is where the bulbourethral gland or Cooper's gland is located. So to go back, male reproductive structure is also included with Cooper's gland, that seminal vesicle, and prostatic gland. Main copulatory organ is penis, as we all know, and the tissue which causes the penis to function are called corpuscle cavernosum and corpuscle spongiosum. Cavernosum and spongiosum, they have microscopic blood vessels, and they are the tissue, fibrous tissue with microscopic blood vessels, can cause the erection. when the blood vessels are pumping blood into the corpus cavernosum and spongiosum. This structure that you see here, the bluish color structure, let me magnify that a little bit. This structure here you're seeing, it gets enlarged and it gets filled with blood and become erected. When the nerve sends out impulse that erection is not needed anymore, then the structure, corpus cavernosum and spongiosum, which is all around the urethra, will release the blood to go back to the pudendal artery where it comes from. Now, we talked about circumcision. When patient has excessive foreskin, circumcision is done, and we have after circumcised tissue, we have this illustration here. So as we have talked, the circumcision can be a quick procedure, can be done during after a couple of days or within a day when the baby is born in the pediatric ward with a clamp called Gomco clamp. We showed you that. We're going to see it again. Now we have some accessory organ. They contribute to the seminal fluid, seminal vesicles. This leaf-like structure, we have two of them, right and left side, and they contribute some fluid, seminal vesicle fluid, into the prostatic urethra. Now, you're hearing this term prostatic urethra multiple times. Urethra, when it comes out from the bladder and it courses through the prostate gland, that section is called prostatic urethra. Then we have the distal part of the urethra that course out through the penis, penile area. So that is why you're hearing seminal vesicle dumps its fluid into the prostatic urethra. Prostate gland, this yellow here illustration, it also dumps its fluid to the prostatic urethra. Bulbourethral gland is situated right beneath the prostatic structure. So it ejaculates its fluid into the urethra. All of this fluid empties into the urethra and makes the volume of the semen. The semen, as you can see, it comes through the vas deferens at the backside of the prostatic urethra. So accessory organ kind of controls the fluid and contributes the seminal fluid volume and alkaline in nature, and allows the sperm to live and function. Now, how do we know that kidney, bladder, urethra has some disease condition? We have a lot of diagnostic tests. One of the diagnostic tests, which is very popular, is called KUB. It's kidney, ureter, bladder, flat plate abdominal X-ray. In the X-ray, kidney, ureter, bladder shows up. And if we have stone, we get spot in that structure. That is how we can tell there is any disease condition or stone lodged in there. Another very popular technique is cystoscopy. Cysto means urinary bladder, and scope is endoscopic visualization of the bladder through urethra and the ureteral orifice and some portion of the ureter as well, using a cystoscope. Cystoscope is not a sterile procedure. As you know, any scopes that is going through the natural orifice of the body cannot be sterile. Once it goes through the natural orifice, it contracts that microorganism that is residing in those natural orifice. That could be mouth, nose, or it could be anal canal, rectum, or also urethra, and also vaginal canal. So anywhere you have natural orifice, you're putting any scope or instruments. As soon as you did that, or your surgeon did that, that instruments and scope becomes unsterile. So cystoscopy procedure where urologists put the scope in and out, give it back to you in your back table, you store, you give it back to them when they need it. So the whole cystoscope procedure is clean, but it's not sterile. We start with sterile instruments, sterile supplies. Once the scope starts, then this is not sterile anymore. You have to kind of remember that. That don't mean that you can get unsterile supplies into your field. Why not? The reason is this scope and the supplies that you have now on your back table, on your field, it is contaminated with only patient's microorganism. That is the resident flora of the patient. What is the patient has that is not causing any infection to the patient? Just like we have bacteria on our skin is not causing any infection to our skin. But if we get microorganism from other source, that can cause infection. That is foreign to our body and it can cause infection. That is why, even though we're doing a non-sterile clean procedure, we still have to maintain sterile technique when you're doing cystoscopy. Oftentimes people get confused. People think, oh, this is not a sterile procedure. Why are you worrying about opening or non-opening a sterile product? You know, you're entering the urethra. What's the matter with you? So why can't we have unsterile ointment, lubricant, or KY jelly? Nurse will have hard time to understand that. This is the reason. The reason is foreign microbes versus non-foreign or residual microbes. There's a difference there. So cystoscopy is done to visualize the bladder, urethra, and ureteral orifice. All the way up to the ureter, they can use ureter scope. There's a finer scope there, which is about a 1 millimeter or 2 millimeter in diameter, very tiny scope. They can put in to see the ureter even. Diagnostic tests like cystogram. When you see gram, that means a graphic examination. So that means a graph will be placed. Cystogram is also a X-ray visualization, the bladder using a contrast media. Gram means visualization or X-ray visualization. Cystogram. Here we can see they can do ultrasonic diagnostic test where they use the ultrasound probe through the rectum, anal canal, into the rectum, and they can reach prostate, underside of the prostate. Here is symphysis pubis, get oriented here. Here is the patient with the lithotomy position, legs are on the stirrup. This is the symphysis pubis, the pubic bone. Bladder is located right underneath. Prostate is located in between the symphysis pubis and rectum. And if you put a ultrasound probe through the rectum, you can actually touch the prostate. You can use ultrasound probe with a needle to take biopsy of the prostate to see if it is cancerous or not. So there is a diagnostic test you can do in this position, in this manner, other than just a plain cystogram of filling the bladder with contrast media. Cystomedogram is this test that you are seeing, where they see how much this bladder can hold. So they fill the bladder with 500 cc's of irrigation, usually water, and to the catheter, and then see the voiding pressure. That is cystomedogram. So they can check the urethra sphincter by doing this. This is very, very important. Retrograde pyelogram. Pyelo means visual examination or X-ray visualization of renal pelvis area or kidney. It refers to kidney with ureter. Pyelo refers to kidney and ureter junction. So what they're doing is they will insert a catheter. We call that ureteral catheter because that catheter goes to the urethra, and surgeon advances the catheter through the urethra, ureteral orifice into the ureter, all the way up to the kidney. Let me show you how this catheter goes up. You catheter and into the bladder. Let's look at a better view here. Here, no, this view. Let's check. This is the view we want. Here, kidney normally secretes the urine through the ureter into the bladder. That is anterograde. That is normal course of traveling through the ureter. Now, retrograde would be backward. That was forward traveling of the urine. If we see a catheter going in here and going downwards, that would be normal course of the catheter along the ureter, because that's anterograde. And that is the way the normal design of this kidney and the ureter. But here, since we cannot access this area without cutting open the the structure here, we use urethra, the natural orifice, to insert the catheter, ureteral catheter, and the catheter pushes through this ureter all the way up to here, the kidney. Now this catheter, now it is going backward into the kidney, right? going from bladder to the kidney, going backward, traveling backward. Now, this catheter, what goes inside, gets the contrast media, like hyopic. Contrast media, which is radiopic, so it's going to show up on the X-ray. So we insert the catheter and we fill these two ureter with contrast media. Then we take a fluoro, live X-ray. That live X-ray will show the contrast media filled in the bladder, going through here and going up. As long as there is no blockage, it is gonna show that it is going without any blockage. But if we have a stone right here, then that will show up as a dark spot. Normally, this will look like a white tubing. Because of the contrast media filled tubing, it's going to look like white. If we have a stone, that stone is not going to show up as a white body. It's going to show up as a dark substance. And we know, the surgeon will know where the stone is. So that is a very, very important diagnostic test called retrograde pyelogram. Many times in the cysto, you will get to see this and do this. There is a technique that you will learn slowly how to do this, because the surgeon, they will be busy with both hands to put the scope inside, the cystoscope inside, and direct that ureteral catheter into the ureter. Once it is situated inside the ureter, then surgeon will ask you to inject that contrast media, hyopic, into the catheter. You will attach the syringe to the end of the catheter, which is outside of the scope, and you will inject hyopic carefully without putting a bubble, air bubble in there. So you have to learn first how to load your syringe with contrast media without any air vacuum. Why? Air vacuum will show up in the X-ray as it will be taken as if there is a stone there mistakenly. So to avoid that mistake, first you have to learn how to fill your 35 cc syringe with hyopic contrast media or renographin or omnipic. These are all contrast media. Hyopic is the one we mostly use in the cysto room. So you learn how to fill that ureteral catheter with that contrast media very slowly. You don't do it very fast. You wait for surgeon's signal. Surgeon will order you. You'll say, go a little bit, and you flush it. You put it in, and surgeon will watch it in the X-ray. Then you go a little bit more. And when the surgeon satisfies, they will also take some flat film, and they can diagnose if there is any stone there or any blockage there or any constriction there in the ureter or in the pelvis, renal pelvis. That is retrograde. Going backward, going from urethra into the kidney. Now, another way they can do that is antegrade. intravenous pyelogram. This way, they will use the contrast media into the IV, intravenous IV solution. They will fill the IV bag with contrast media. Now, what happens when you fill IV with contrast media? That contrast media is going to travel through that intravenous route into the heart, from the heart into the renal aorta, into the renal artery, into the kidney. Then from kidney, it is going to filter through and comes out of the renal pelvis, and it's going to come out through the ureter into the bladder. So that is the normal course of traveling anyway. So we call it intravenous pyelogram, IVP. And this is done to diagnose if there is any stone or there is any defect there in the kidney ureter. Now, the stone that you get is calculi. It's a mineral deposit, mostly calcium, magnesium, and stuff like that. Stone, if you put them in the water or saline, it will dissolve. And the pathologist won't be able to examine that. So that is why we don't put stone in any saline or water, any solution at all. We put them in a dry container, usually dry glass container that the nurse will have. They will get it out from the cabinet, and you will pick up the stone with a tissue forceps, carefully place the stone inside that container, and they will take the dry container to the pathologist for examination. So this is a very unique test, retrograde pyelogram and antegrade intravenous pyelogram. Now, we're talking about irrigation that we need. For cysto, like where you use diagnostic scope to see the bladder, ureter, that is called cystoscopic procedure. You need fluid which is sterile, which is non-hemolytic, means it is not going to break down the blood, which is non-electrolytic, means it do not have positive and negative ion. And when you are using electric or laser, you should not use electrolytic fluid. So non-electrolytic, non-hemolytic solutions are available in a large 3000 cc bag. Examples are 1.5% glycine, sorbitol, or irrigate. These three irrigations are perfect for any diagnostic or any cystoscopic procedure. Irrigating solutions that's sterile and it is hung by the nurse, or it can be pressurized in a equipment. So depending on what the surgeon need is, surgeon may want that hang the bags on the IV pole. That's fine. They may want it pressurized with a pressurized equipment. If you are not using electric or laser, and it is a very quick procedure, then surgeon may accept sterile saline or sterile water, but they will tell you. They'll tell you when they accept sterile saline or sterile water. They'll tell you at the beginning of the case. But if you use these non-electrolytic D solutions, 1.5% glycine, sorbitol, uricate, you're not going to have any trouble. When you are resecting prostate, or you are resecting tumor from the bladder neck, the procedure is called TURP, transurethral resectoscope of resection of prostate, transurethral. So the big scope is going through the urethra all the way up to the prostate, and through the scope, they'll use cautery to resect the prostate. Similarly, if they need to remove a tumor from the bladder, they can do a transurethral resection of bladder tumor, or TURBT. In both cases, they will have blood clots, tumor tissue floating around inside the urinary bladder after resection. We call prostatic chips or bladder chips. They'll be floating inside the bladder. Then you need to have these instruments to get rid of those chips from the bladder. One of them is called iliac evacuator. It's a very unique design evacuator for urology. It has double bowl shape evacuator, means it has a glass or plastic bowl, double bowl attached to each other, and then there is a evacuator. This is used normally to get rid of the prostatic blood clots and tumor from the bladder. They have Toomey syringe. This is just a syringe, but it's got a wide opening, very, very wide barrel syringe. We got piston syringe, where this piston syringe can be hooked up to a Foley catheter and evacuate these resected tumor or bladder clots. Using iliac or Toomey or piston will be directed by the surgeon ahead of the case. They will say open a iliac or Toomey, whatever they want. Usually they start with iliac. During the case, while they're resecting, they will use iliac. When the case is done, then they will use either Toomey or piston syringe, one or the other. Catheters that we use, some of them are ureteral, which is to go inside of the ureter. They're sterile, disposable, and they have marking like graduated. These catheter, as you can see, there are many different types of tip: olive tip, blunt tip, angle tip, straight, and these are another type of catheter. They're called stent catheter. They're there to keep inside the ureter temporarily. These catheters that you see here, they are for procedure. And this the curved end catheter that you see, they're called stent catheter. Therefore, temporary diversion of the urine. When the ureter is blocked, this catheter maintains a passage through the ureter into the bladder. When they're doing any large procedure, big procedure of the pelvis, like hysterectomy maybe, they're working very close to the ureter. So they put catheter in to palpate from outside, not from outside of the body, into the abdominal pelvic cavity, but outside around the course of ureter, they can palpate and see where the ureter located. So that is used as a landmark. Size is French. 5 French is most commonly used ureteral catheter for diagnostic purpose. You use this catheter to inject contrast media. So catheters are important. Now, urethral catheter that you see could be used as a drainage process. It could be plain or indwelling. Plain means a catheter placed just to drain the urinary bladder before the case. Indwelling catheter, on the other hand, nurse or you will put it inside the bladder through the urethra and you will keep it there for certain period of time. Indwelling catheter, they're self-retaining. So if you put it inside this Foley catheter, you know you can inflate the balloon of the Foley catheter with sterile water, and that balloon will keep the catheter inside the urinary bladder and drain it all the time. Similarly, you have self-retaining catheter called Peezer. It looks like mushroom. So the mushroom end will stay inside the body, inside the urinary bladder, as long as it is deployed. This catheter is known as Peezer. It's used not through the urethra. You have to make a separate incision through the skin. Underneath that, on top of that pubic bone, that is why it's called suprapubic, to drain the bladder after prostate surgery most of the time, or other urinary bladder surgery. Malcut, instead of mushroom, they got bat wing. When it is deployed, the wing will hold the catheter. Malcut is used for kidney drainage, nephrostomy. When they are doing kidney-related surgery, they will, after the surgery is done, they'll put Malcut catheter in the kidney so it can drain the urine from the kidney. Here are the catheters we normally use. Red one you see, it has no balloon. This is the tip and this is the end. You put the catheter in with a little bit of KY jelly and it will drain urine through this end. Once it drains the urine, you take it out, throw it out. It's disposable. Now, if you use Foley catheter, this is the tip of the Foley when it is inflated. And this is the end of the catheter. This is the end through which urine comes out. And this is the tip where you put the sterile water in using a sterile syringe to inflate the balloon. When the balloon is inflated, this is what it's going to look like. It's going to be inside the bladder, and the balloon will hold the catheter as long as you want. Similar thing you could do with this Peezer, this mushroom-shaped catheter. You can put it in, and it is going to hold inside like this balloon. And this bat wing catheter, you can put it in the kidney. So 4 different types of catheter normally routinely used for urethra and kidney. Okay, so equipment and instruments. During our cysto diagnostic case or cysto case to remove disease condition, tumor, malignant or benign, we use cystoscope. And cystoscope basically is this straight, rigid telescope and flexible telescope also we will show you. This rigid telescope requires a cysto sleeve and cysto obturator. And the telescope will be then attached to this functional or working element. Working element, you are going to put the cystoscope through this end and lock it. And this has stopcocks. And this end, the cystoscope will come out. The telescope will be right here, the black end. And you have resectoscope. Resectoscope sleeve and this pistol grip, actual resectoscope. What do? You put a electrode through this channel here, all the way up to the tip. And through this tip, you put this telescope in there. So you will have telescope through this sleeve, a electrode through this sleeve, and this cautery cord will be hooked up to the side of the electrode here, plug. And the plug end will go to the bovie. And there will be a foot pedal which the surgeon will have on the floor. When they activate that foot pedal, that electrode will either cauterize or coagulate the tissue. If they want to cut it, they can use cutting current. If they want to coag the bleeding, they can use coagulation current, just like bovie. While they're doing it, they can directly observe it through this telescope. So, resectoscope, this pistol grip that you see is basically Stern-McCarthy. You also have these others. But the Stern-McCarthy is very useful resectoscope. So telescope, cutting electrode with this cutting electrode cord, working element right here, sheath. These are all sleeve or sheath, and obturator. These are the components for your cystoscope and resectoscope, primary component. This is what they will do. This illustration shows. They will put the cystoscope through the urethra into the bladder, hook up the cord, light cord here to the telescope, and hook up irrigation catheter, irrigation tubing to one of the stopcock, irrigate the bladder to inflate, otherwise bladder will be collapsed. They won't be able to see anything inside the bladder. They'll irrigate it to keep the bladder inflated, and they can see through the telescope directly inside the internal structure of the bladder, the prostate, urethra. Even the longer telescope, which is called ureteroscope, they can see the ureter also. Patient is in lithotomy position. As you can see, here's the buttock, here's the leg, the thigh is on the stirrup. When they open the prostate area, then we call to get to the prostate through the urinary bladder, we call it cystotomy. Cystoscopy, looking through the scope, no opening there, no incision there. No incision is required, right? Cystoscope, it is an endoscopic examination. Cystotomy is an opening by making an incision using knife blade. So they do that for prostate surgery, suprapubic prostatectomy, or any other type of prostatectomy that we are going to see later. And here is what we talked about. Circumcision, basically, using these Gomco circumcision instruments. Excess tissue, which is known as phimosis, is removed by using this Gomco clamp. And they will put Vaseline gauze as dressing, and it will recover very quickly. Newborn, they don't even need any anesthesia for this type of case. Circumcision. So to go back to refresh the anatomy of the genitourinary system, we see here in this illustration kidneys bilaterally located retroperitoneally. So as I told you before, that we have to go through a few layers in the body in order to get to the retroperitoneum. That is the backward, retro means backward, located backwardly. So in order to get there, we go through anterior peritoneum, we enter the abdominal pelvic cavity, then we retract the omentum small intestine, large intestine, mesentery, and then we reach the layers of retroperitoneum. Surgeon will pick it up with tissue forceps and incise it, open the retroperitoneum, and then they can see, visualize vena cava first, then the aorta, and if they look left and right, they will find kidney in capsule in the aorta's capsule. Kidney won't be visible like this, dark brown. They're going to see yellow fatty tissue covered kidney. That yellow fatty tissue cover is aorta's capsule. And on top of that, they will see adrenal gland. Though also you can see the area we call hilum, the concave area of the kidney, and renal pelvis. We call this funnel-like area where blood vessels, large renal artery, renal vein are going in and out. Large funnel-shaped ureter comes out from there and narrows down and courses its travel to the backside of the bladder when it descends. Urinary bladder is sac, kind of triangular in shape. That's why we have the edge here where there is a urethra. That's the edge of the triangle we call trigon. And we have these hole through which ureter opened up into the urinary bladder, bringing in urine. So kidney filters the blood, produces the urine. Urine comes out through the ureter, through peristalsis, enters the bladder. When the bladder is filled, bladder opens the sphincter, it empties through the urethra outside of the body. Male urethra is long, female urethra is short. This is the basic anatomic structure. Now, if you go further down, if you want to continue to dissect to get to, you'll find retroperitoneal lymph nodes. There's a lymph glands, lymph channels going by the backside of the body. If you go further down, you're going to find the vertebra, the lumbar vertebra, anterior body of the lumbar vertebra. Then you know you have reached the backbone. Now, if we see in this view, which is magnified view, which I talked about, the reason I'm reviewing it again, because this is important for you to understand. Magnified view gives you better understanding of the aorta coming out through the diaphragm, hiatus of the diaphragm, and these muscle structure called psoas major or iliopsoas. They are located from the iliac crest all the way up to the diaphragm at the back side of the body, all around it. That's the back wall of the body. That is where the kidney's aorta's capsule is attached. The psoas major fossa. Fossa is a depression. That is where the kidneys, these bean-shaped organs, are attached by the connective tissue, aorta's capsule. So in order to remove, they need to go through Geroda's capsule. Then they need to ligate these big, large vessels, renal artery, renal vein. They need to ligate this ureter, then slowly dissect it around the tissue to remove it for nephrectomy or kidney removal. That is why we need to know these structures. So we need to know where surgeon is working. Is the surgeon working on the Geroda's capsule? Then we have to give them tissue forceps, long tissue forceps, right angle, or Kittners to blunt dissect that area. If they're working around the renal vessels, then we have to give them right angles, renal pedicle clamps, scissors, sutures, clips, tie on a passer. They're working around the ureter, then we have to give them vessel loops. We have to provide them right angles. They like to use knife blade here when they cut the ureter. And we have to insert catheter there also to keep the rest of the ureter intact for future connection. So we need to know this structure. This is a structure that you're looking here is the coronal section, mid-coronal section of the kidney. Anterior half of the kidney is removed. Now we are seeing posterior half. This structure that you see right here, the funnel-like structure is renal pelvis. And this middle structure you see is a medulla, dark brown kind of structure, looks like pyramid, upside down pyramid. And then we have cortex, which is the outer layer. Magnified view gives you this nice kidney functional units, which is called nephron. Nephrons, if we go to evaluate this structure, we go from outside to inside. We come from outside of the kidney, which is the Geroda's capsule. After the Geroda's capsule, we come to the cortex area. This is the outer surface called renal cortex. Then we come to these dark brown structure, which is like upside down pyramid. They are called renal medulla, functional unit. And we see these vessels, they are kind of circulating all around these renal medulla. These are the renal arteries capillary beds, which is going inside of the medulla through convoluted tube or loop of Henle. Those are the internal structure that we don't have to really see here, that you have learned in the physiology part. So renal medulla. Then renal medulla tip, which is called calyx renal papilla, is coming to this off-white color structure channel. It's called calyx structure. Calyx become major calyx when multiple calyx are collected together in a major funnel-like structure called major calyx. So major calyx then become renal pelvis and courses down as a ureter. Now, blood vessels bring in blood through the aorta, goes into these renal medulla functional unit. Their blood is filtered, minerals are put back in the blood, bad toxin material like urine uric acid is collected through this papilla into the calyx. The urine is collected here, and renal pelvis then channel the urine into the ureter to the bladder to eliminate from the body. So this is how the kidney functions, and this is the anatomical structure of the kidney. And as you can see, when you're doing the dissections, your surgeon, you have to really be prepared to ligate a lot of large vessels. They're everywhere. These vessels are everywhere, and you have to ligate them properly and reinstate the ligation with double ligation clips. Make sure you're prepared for that. We're going to go through that kidney resection later, so we will talk about what are the steps for the nephrectomy or kidney resection. So this is where I stop today, and tomorrow we'll pick it up and continue the procedures for the genitourinary surgery, including the kidney and ureter. All right. Now we are going to open up for any question. And after the question, you should be able to log out, since I have, we kind of extended our session to the lunch. Do you have any question at this time? Please feel free. Yeah, chat is okay. Ruby said, no question for now. Okay, I understand that you have to go through this, study this. Tomorrow you'll have some questions to ask, but study the anatomy, reinstate your anatomy, refresh it. That way it will help you understand the urological procedures. All right. Anybody else has question? If you have question, please say so, or you can wait after everybody leaves, stay here to ask questions after the lecture. That is fine. And I'm going to stop the recording right now.